morning and welcome to this session of the Maine Public Health Association annual meeting. It's certainly been going very interesting. The first time we've done a virtual approach to the meeting, and I'm so pleased to be able to introduce Dr. Amanda McKinney. She's founded the Institute of Human and Planetary Health at Doane University to improve both human and planetary health by harnessing the power of plants grown sustainably for both medicine and food as a way to prevent and reverse disease. She attended the University of Nebraska College of Medicine and completed her residency and fellowship training at the University of California, Irvine. I might also note that Dr. McKinney is an associate of Dr. Caldwell Esselstyn Jr., the author of Prevent and Reverse Heart Disease, a best-selling book which brought a lot of attention to plant-based nutrition. And we hope to engage her in programs here in Maine early next year. So welcome, Dr. McKinney.
Thank you. Good morning, everybody. I hope everybody is feeling well today. So let's get started. I'm going to be talking about how lifestyle medicine, particularly diet, can be used to prevent and reverse cardiovascular disease. Just a little housekeeping. I have no commercial relationships to disclose. So the objectives for this talk, as you can see here, are to understand the core competencies of nutrition, tobacco cessation, and alcohol and their interaction with cardiovascular disease, to recognize the difference in efficacies of traditional treatments versus lifestyle-based treatments for cardiovascular disease, and to identify effective lifestyle-based treatment protocols used to prevent and treat cardiovascular disease. So the American College of Lifestyle Medicine defines the discipline of lifestyle medicine as involving the use of evidence-based lifestyle therapeutic approaches, such as a predominantly whole food, plant-based diet, exercise, sleep, stress management, alcohol moderation, and tobacco cessation, and other non-drug modalities to prevent, treat, and oftentimes reverse the lifestyle-related chronic diseases that are all too prevalent. So fully 80% of the healthcare spending in the US, which by the way is over $3.5 trillion with a T, over 80% of this is due to the treatment of conditions that are rooted in poor lifestyle choices or access. So using lifestyle changes to treat chronic conditions like obesity, heart disease, hypertension, type 2 diabetes, and many types of cancer is actually treating the cause rather than just treating the symptoms. So the vast majority of these chronic diseases are the result of feet, your physical inactivity, forks, what we elect to put on our mouths 3 times a day, and fingers, whether or not we choose to smoke. Other contributors to chronic disease are lack of sleep, high stress levels, and lack of connection with other humans that is common in today's society. So not only can we prevent diabetes, heart disease, and cancer, oftentimes we can actually reverse the disease with a whole foods, plant-based diet, moderate exercise, smoking cessation, and stress management. People can actually eradicate their diabetes, heart disease, and high blood pressure without pills or procedures. And according to the Global Burden of Disease Study, which was a collaborative effort that assessed the risk factors for death and disability for 167 countries between the years 1990 and 2010, the #1 cause of death and disability in the United States is our diet, followed by tobacco use. So smoking is responsible for approximately 450,000 deaths annually, while diet is responsible for close to 700,000 deaths annually. And I also want to note here that the feet, forks, fingers, sleep, stress, and love is something that Dr. David Katz came up with from the Yale Research Prevention Center. So heart disease kills more Americans annually than all of our past wars combined. And 25% of the time, the first symptom of coronary artery disease is sudden death. So 55% of men and 68% of women who die of sudden cardiac death have no prior warning of significant heart disease. And heart disease is America's #1 killer for all of those over the age of 35, with cancer becoming a close second. And treatment of heart disease is an expensive proposition. In 2018, the cost of treating cardiovascular disease in the US was $200 billion and is expected to nearly triple to $545 billion by 2030, according to a policy statement by the American Heart Association. So this spending accounts for 1 in 6 of every healthcare dollar spent in the US, the majority of which is spent on diagnostic procedures and treatment with angioplasty and bypass surgery. In comparison, the estimated total cost for treating cancer in 2018 was $125 billion. And the lifetime medical cost for each patient with heart disease now averages more than $750,000, approaching $1 million for some patients. And heart disease actually begins in childhood. Studies of accidental death victims between the ages of 3 and 26 found that fatty streaks, which are precursors to atherosclerotic plaques, were found in nearly all American children by age 10. In some cases, atherosclerosis may even begin before birth. Some Italian researchers evaluated arteries from miscarried fetuses and premature newborns who died shortly after birth and found that the arteries of the fetuses whose mothers had high LDL or bad cholesterol levels contained these fatty arterial lesions. In addition, autopsy studies of American soldiers that died in the Korean War revealed that 77% of these young men, whose average age was 22, had visible evidence of coronary atherosclerosis. Some of them even had arteries that were blocked 90% or more. All of these studies reveal in a dramatic way that atherosclerotic changes appear in the coronary arteries years before the age at which coronary heart disease becomes a clinically recognized problem. So, as just discussed, the earliest visible lesion of atherosclerosis is the fatty streak, which is an accumulation of lipid-laden foam cells, and we're going to talk about these in a little bit, in the intimal layer of the artery, which is just above the single cell endothelial cell layer. And the hallmark of atherosclerosis is the atherosclerotic plaque, which is just an evolution of the fatty streak. So initiation of atherosclerosis is often in response to endothelial cell injury and is mediated by inflammatory substances called cytokines. So endothelial cells line the walls of the blood vessel and produce nitric oxide, which is a potent vasodilator and also an anti-inflammatory molecule. Often, atherosclerosis preferentially affects areas like arterial branch points where the blood flow is very turbulent. And this leads to endothelial dysfunction and injury and prevents the endothelial cells from producing this nitric oxide. Instead, this turbulent blood flow stimulates endothelial cells to produce adhesion molecules, which recruit and bind inflammatory cells. And then this leads to a migration of monocytes and T cells into that subendothelial space. And these monocytes are transformed into macrophages. And then LDL and VLDL, the really bad cholesterol particles from the blood, bind to those endothelial cells and they're oxidized. And then these macrophages take up these oxidized lipid and they eat them and they transform into these foam cells. And these foam cells are exactly what they sound like. And when many of them aggregate together, they create these fatty streaks. So over time, these foam cells produce additional pro-inflammatory cytokines. So it's self-perpetuating. And they recruit smooth muscle cells to migrate from the media, which is an intermolar layer of the artery, into the intimal layer. And this causes the intima to thicken. This further attracts and stimulates growth of more macrophages and more foam cells. And then the end result is an atheroma with subsequent accumulation of lipids inside there. It's kind of like a big pimple. Now, at this point, these plaques may be either stable or unstable. So depending on the internal milieu of the body, stable plaques may form and can either regress, they can remain static, or they can grow slowly over several decades until they cause stenosis or occlusion of the vessel, resulting in decreased blood flow and anginal symptoms like chest pain with exertion. Now, stable plaques tend to be older, with their inflammatory status has abated in areas of less turbulent blood flow. And they typically have been infiltrated by more smooth muscle with a lower content of lipids and inflammatory cells. And instead, they have more fibrotic tissues with a thicker and more calcified cap over the top. They often narrow the vessel lumen by less than 50%, and they may or may not produce a predictable exercise-induced stable angina. So plant-based diets, which are anti-inflammatory, low in cholesterol and saturated fat by nature, can help plaques become stable, which reduces both morbidity and mortality. So heart attacks are typically the result of unstable plaques rather than the progression of a more stable plaque that narrows the channel of blood flow and causes chest pain. So in the case of a myocardial infarction or heart attack, inflammation stemming from the damage of the inner lining of the artery accelerates this atherosclerotic plaque to a point where it suddenly ruptures. And the majority of ruptures originate from non-obstructive plaques that don't cross that 50% threshold. So these unstable plaques are very vulnerable to rupture long before they actually cause significant stenosis that results in symptoms. And plaques tend to rupture where the cap is the thinnest and most infiltrated by foam cells. The weakest spot is often at the cap margin or the shoulder. And only extremely thin fibrous caps in the range of 23 to 65 microns are at risk of rupturing. So thinning of the fibrous cap is thought to be the result of two different mechanisms. So one is the gradual loss of smooth muscle cells from the fibrous cap. And the second is infiltrating macrophages resulting from an inflammatory milieu in the body, which degrades the cap matrix. So it actually dissolves it. So ruptured caps that have been examined at autopsy are usually very heavily infiltrated by these macrophage foam cells, which secrete these substances that are capable of degrading virtually all the components of the cap matrix. So whether thinning of the fibrous cap takes decades to evolve or is much more dynamic is not known. However, atheromas or plaques with fibrous caps are commonly seen from the age of 30 years onward. But coronary artery syndromes, like heart attacks, are exceedingly rare in this age group. So it seems to indicate that it's a slow, smoldering process with plaque instability. Conversely, it's well known that plaques can become unstable relatively quickly in certain settings. In some cases, a temporary increase in emotional or physical stress provides the final triggering of the event. So stress can cause an increased inflammatory response, as well as a rise in blood pressure that can destabilize the cap. And other recognized triggers include physical activity, sexual activity, anger, anxiety, work stress, earthquakes, war, terror attacks, temperature changes, infections, and cocaine. And there's also a link to the circadian rhythm, and it may explain why heart attacks are more frequent in the morning. So dangerous eating can also lead to a destabilizing plaque and leading to rupture and thrombosis. So autopsies of persons who have died from heart attacks have revealed that cholesterol crystals are actually protruding from these ruptured plaques. So some researchers hypothesize that when a soft atheromatous plaque with large lipid pools becomes supersaturated with cholesterol, it can undergo a physical transformation from a liquid to a solid crystal state. And the growing crystals can then expand within the confined space of the plaque and rupture and damage the fibrous cap. And the ability for this to happen was actually confirmed with laboratory experiments. So this likely explains the uptick in cardiac events that occurs around holidays. So it was once hypothesized that the cold weather and increased snow shoveling was what precipitated heart attacks on Thanksgiving morning or Christmas morning. But what we know is that this phenomenon occurs in warm weather cities like Los Angeles as well. So it's possible that large high fat meals can be destabilizing plaques. And it's known from this research that alterations in the plaque's physical conditions may promote cholesterol crystallization. And these include low temperature and changes in pH and increased local tissue concentration of cholesterol. So there appears to be a critical amount of cholesterol concentration that's needed for supersaturation to initiate crystallization. And once crystallization starts, it proceeds rapidly and forcibly to damage the overlying cap. Now, as we discussed previously, inflammation has been considered the primary initiator of plaque disruption. And the exact mechanisms leading to the cap rupture were not necessarily known. But crystallization of cholesterol can rupture this membrane by stretching and tearing the cap. And then that stimulates a localized inflammatory response that then causes more accumulation of macrophages and other inflammatory cells. And it's quite possible that just eating a meal that's very high in cholesterol can actually do this. So the cholesterol in eggs, when consumed, doesn't cause a significant increase in fasting blood cholesterol, but it does cause a substantial increase in the blood cholesterol after a meal containing eggs. So a meal containing eggs is known to increase heart attack risk. After the meal, the blood cholesterol and other lipids and oxidative stress increase for several hours. And so the mechanism for this increased heart attack risk may actually be intraplaque cholesterol, supersaturation, and then crystallization. So regardless of the cause, once a plaque ruptures, the plaque contents extrude out into the blood vessel and are exposed to the circulating blood, which triggers blood clot formation. And the resultant clot may be incorporated into the plaque and changing the plaque's shape, causing its rapid growth, occluding the artery, and then rapidly occluding the vascular lumen, precipitating an acute ischemic event. Or this blood clot can actually embolize and go downstream and occlude blood vessels there. The clinical consequences of a ruptured plaque can include sudden cardiac death or infarction and death of the heart muscle to varying degrees, depending on how much blood flow and oxygen was restricted to the muscle. So the outcome is dependent, again, on plaque location, a relative balance of procoagulant and anticoagulant activity in the blood, and the vulnerability of the heart muscle to arrhythmias. Atherosclerosis is initially asymptomatic, and that's often asymptomatic for decades. Symptoms and signs develop when a lesion impedes blood flow. Symptoms caused by transient lack of blood flow, like stable angina with exertion and intermittent claudication in the legs, typically develop when a stable plaque occludes the arterial lumen by more than 70%. Severe or complete stenosis can also result from vasoconstriction, so constriction of the vessel that typically does not limit blood flow under normal circumstances. So stable angina is defined as chest pain that increases with activity and exercise and then improves with rest. The acute coronary syndromes include myocardial infarction or heart attack, and then unstable angina. Unstable angina occurs at rest, not during exertion, and it signals a significant increased risk of heart attack and should be treated as a medical emergency. Stable angina is relatively easy to diagnose. However, the prediction of those that are at high risk for plaque rupture is problematic. Stress tests only pick up plaques that obstruct by about 50% or more, but 70 to 80% of all heart attacks are caused by those younger, more inflammatory plaques that are less than 50% obstructive, and they're not invisible oftentimes on angiography or other stress tests. So when imaging techniques such as invasive coronary angiography or CT angiography are used to view the coronary artery vessel wall, areas of plaque that are too small to impede blood flow will show up in only about 30% of people referred for testing who haven't already been diagnosed with heart disease. Other various imaging technologies are currently being studied as a way to identify plaques, that are especially vulnerable to rupture. CT angiography is used as the initial screening test, But catheter-based tests, including intravascular ultrasonography, plaque thermography, and others, can also be utilized. Interestingly, down at the bottom, you can see that many clinicians use serum markers of inflammation like the CRP test or the C-reactive protein. And a CRP of greater than 3 milligrams per deciliter or 3,000 micrograms per liter are highly predictive of cardiovascular events. Also, the Framingham 10-year coronary risk prediction model tool is often used to predict the likelihood of cardiovascular events in the next 10 years of a patient's life, but it tends to overestimate risk. So the difficulty in prediction led Dr. Lewis Culler, a professor of public health from the University of Pittsburgh, from his 10-year cardiovascular health study to make this statement. All males who are 65 years of age and older who have been exposed to the traditional Western diet have cardiovascular disease and should be treated as such. Given the autopsy studies discussed earlier, this statement can also likely be applied to many men younger than 65, as well as women over 65 and higher risk women under the age of 65. In addition, family history can be useful when heart disease is present, but absence of a positive family history does not help rule out risk because heart disease is not genetic. We know this from both epidemiologic studies as well as autopsy studies. Dr. T. Colin Campbell of the China study and his co-researchers investigated the eating habits and incidence of chronic disease among hundreds of thousands of rural Chinese. In Guizhou province, a region comprising about 500,000 people, over the course of 3 years, there was not one single death that was attributed to coronary artery disease among men under the age of 65. Likewise, British and American physicians who were working in Uganda during the 1930s and 40s described the incidence of coronary heart disease as almost non-existent. Autopsy studies of age-matched Ugandans confirm this observation. Out of 632 autopsies on Americans, there were 136 heart attacks, while there were 0 heart attacks in the 632 Ugandan autopsies. Another Ugandan autopsy study revealed 0 fatal heart attacks out of 800 autopsies performed, and 1 non-fatal heart attack was identified. This low rate of heart disease in rural Chinese and Africans has been attributed to the average cholesterol levels in these populations being 150 milligrams per deciliter, which is similar to contemporary people who consume plant-based diets. This is in contrast to Americans who have an average cholesterol of over 200. In addition, when people move from low risk to high risk areas, their disease rates rise to the levels of the individuals around them as they adopt these new diet and lifestyles. We also have evidence from the North Karelia project in Finland that getting people to consume less saturated fat on a population level can significantly impact mortality from cardiovascular disease. At the time, the US was second only to Finland in cardiovascular mortality. The North Karelia project was launched in Finland in 1972 in response to the exceptionally high rate of coronary heart disease mortality in the area. The project was formulated and implemented to carry out comprehensive community and individual interventions that focused on lowering cholesterol through reduction of saturated fat intake. The government went even so far as to subsidize farmers in order to help them transition from dairy farming to berry farming, for which this project is more popularly known. The 25-year retrospective results revealed that there was a 17% decline in average cholesterol level, but there was an 80% reduction in cardiovascular mortality, 80% reduction in cardiovascular mortality, with an 85% reduction in this region of North Karelia. They also realized a 45% reduction in all-cause mortality and a 7-year increased life expectancy for men and 6 years for women. This remarkable reduction in cardiovascular mortality took place in the era before statins. The capacity of a healthy lifestyle to prevent cardiovascular disease is not a novel concept, Both the Inner Heart Study and the Nurses' Health Study showed that more than 90% of heart attacks can be prevented by adherence to healthy lifestyle habits. So the presence of atherosclerotic disease in one vascular territory increases the likelihood of disease in other vascular territories. Atherosclerosis can lead to sexual dysfunction in both men and women, Alzheimer's disease and other dementias, stroke, chronic low back pain, and claudication. Patients with these non-coronary atherosclerotic vascular lesions have cardiac event rates that are comparable to those patients who have known coronary artery disease. And they are now considered to have coronary artery disease risk equivalent and should be treated just as aggressively. Diabetes is also considered a coronary artery disease risk equivalent, meaning that if you have diabetes, you are deemed as having cardiovascular disease, even if you do not have symptoms. So historically, treatment has largely relied on drug treatment of diagnosed risk factors with medications like statins, ACE inhibitors, beta blockers, antiplatelet drugs, with a focus on lifestyle changes being relatively modest. However, the only critical risk factor for atherosclerotic plaque buildup is an elevated serum LDL cholesterol, so bad cholesterol. Autopsies of thousands of young accident victims have shown that the level of serum cholesterol correlated exactly to the amount of atherosclerosis in the arteries. So, to become heart attack proof, evidence has shown that an LDL of less than 70 must be achieved. The only way to do this is to put Americans on lifelong high dose statins or recommend that they eat a whole food plant based diet. Other lifestyle changes should include smoking cessation and regular moderate physical activity. Historically, drugs to treat dyslipidemia, hypertension, and diabetes have been required, but dietary modification and these other lifestyle changes directly or indirectly improve endothelial function, reduce inflammation, and improve clinical outcome. So the body is amazing, and it has the innate capacity to heal itself. Something we've known for a long time is that if you're a smoker but you quit, after 15 years, your lung cancer risk approaches that of a lifelong non-smoker. Because of this ability to heal when the offending agent is removed, reversal of coronary atherosclerosis is possible and has been demonstrated by the work of Dr. Caldwell Esselstyn, my mentor, and Dr. Dean Ornish. And according to Dr. Joel Fuhrman, all heart disease is reversible with the exception of approximately 1% of people who has advanced valve damage, a genetic defect, or an electrical pathway disease. So this is sometimes referred to as the best kept secret in medicine. Now, we're not trying to keep it sacred, it's just everyone else appears to be. In Dr. Esselstyn's original published research, they followed 198 patients with established cardiovascular disease. The patients were counseled and transitioned to plant-based diets devoid of dairy, fish, meat, and oil as an adjunct to their usual cardiovascular care. Of the 198 patients with cardiovascular disease, 89% were adherent to the diet, and of those adherent patients, there was only one major cardiac event judged to be recurrent disease, which was a stroke for a recurrent event rate of 0.6%. Conversely, 62% of the non-adherent participants experienced adverse events. Both Drs. Esselstyn and Ornish have demonstrated angiographic evidence of plaque regression or resolution. In an important study by Dr. Ornish, angiographic reversal was noted. In the experimental group who ate a plant-based diet, exercised, and meditated, the average percent diameter stenosis decreased by 1.75 absolute percentage points after 1 year, and by 3.1 absolute percentage points after 5 years, which equates to a 4.5% and 7.9% relative improvement, respectively. In contrast, the average percent diameter stenosis in the control group increased by 2.3 percentage points after 1 year and 11.8 percentage points after 5 years, which was a 5.4 and 27.7 relative worsening. These between group differences were significant. This may seem like a small improvement, but it is, and my internet connection's unstable. So if I lose you, I apologize here. It says that this may seem like a small improvement, but it's clearly enough to improve myocardial perfusion because the patients in the experimental group had a 91% reduction in reported frequency of angina after a year and a 72% reduction after 5 years. So their symptoms actually went away. In contrast, the control group patients that had worsening of their stenosis had a 186% increase in the frequency of angina after 1 year. This reduction in symptoms may also be due to the rapid improvement in endothelial dysfunction when eating a plant based diet, as production of nitric oxide is restored and blood vessels have an improved capacity to dilate. In addition, the experimental group had substantially increased myocardial perfusion with decreased myocardial perfusion in the control group. And finally, there were 2.2 cardiac events per patient in the control group, compared to 0.89 events per patient in the intervention group. And there was a dose related response that was noted. So those that were more adherent to the lifestyle changes made more changes overall had better outcomes. The plant based diet group also has the important benefit of stabilizing those plaques, which make them less likely to rupture. So, improvement in these anginal symptoms often happens very rapidly. Another large study that Dr. Ornish did revealed that 75% of patients were completely free from anginal symptoms and chest pain within 12 weeks of starting the plant based diet. This is far better than a drug called Ranexa or ranolazine, which is an anti angina drug. And when that one is taken by patients with angina, it was able to prolong exercise duration by 33.5 seconds. Okay, so a quick note here about atrial fibrillation. Atrial fibrillation affects about 2.7 million people in the US, and its prevalence is expected to rise to about 15.9 million by 2050 because of an aging population. And even though population aging is an important contributing factor, there are several risk factors such as hypertension, diabetes, obesity, and sleep apnea that have also been linked as promoters of atrial fibrillation as well. So what's only recently being discovered is that reduction of obesity and controlling of these risk factors can significantly improve both the management and the chances of reversal of atrial fibrillation. So a study of patients with atrial fibrillation found that a 10% or greater weight loss resulted in a six-fold greater probability of arrhythmia-free survival compared with controls. And in addition, while catheter ablation of atrial fibrillation, so they go in and they buzz the nerves in the heart muscle, that's evolved as an effective therapy for drug refractory symptoms and has advantages over drugs, including rhythm control, and reports of long-term outcomes of atrial fibrillation demonstrate that there's attrition with this treatment method over time. However, it's been showed that procedure arrhythmia-free survival is markedly better in patients who have management of these risk factors. So symptoms of angina can also be resolved with bypass surgery and angioplasty. However, neither of those treatments prevents future cardiac events or extends lifespan in those with coronary heart disease. Because these surgical procedures only treat a very small minority of the plaque burden, they relieve symptoms only temporarily. And without treating the cause, the disease process remains, which allows advancement throughout the coronary vasculature. In addition, these surgical procedures are not without significant risk and cost. So risks of bypass grafting include increased risk of stroke and overall death rate, loss of mental function in the elderly, and atrial fibrillation. The decline in mental function is most severe right after surgery. At the time of discharge from the hospital, somewhere between 50 and 80% of patients have signs of acute mental decline. And even 5 years after surgery, a 20% reduction in mental function has been found in almost half of patients. An MRI study found that brain damage in 51% of patients after bypass, and 3 years post-op, there was a permanent reduction in mental capacity in 31% of patients. And symptoms can include sleep disturbances and nightmares, depression, mood swings, and lost intellectual ability. Current guidelines state that there's no significant data to recommend patients that have stable coronary artery disease should be evaluated with angiography or treated with bypass or with a stent or angioplasty and or stent. And this is because a recent meta-analysis of 28 studies that compared cardiac surgery with medical therapy found that there was a less than 2% absolute improvement in survival achieved with surgery. And for older patients who are 80 and above, the risks are even higher. Multiple studies have confirmed that the risks of complication, death, and prolonged hospitalization in this group. An octogenarian's 30-day mortality rate is 9% compared to 1.2% for those that are younger than 80, which is 72% higher. They also have a 3% longer hospitalization, a 51% increased risk of neurological complications, and were 49% more likely to undergo repeat surgery for bleeding. Percutaneous coronary intervention or angioplasty with stent carries risks as well that includes death, heart attack, stroke, ventricular fibrillation, and aortic dissection. Myocardial infarction occurs in about 3 to 5% of patients who undergo angioplasty. And one study showed that 1.2 patients out of every 100 undergoing this procedure actually die. Like bypass surgery, the complications of angioplasty with stent are more likely to occur in people older than 70. And in addition, angioplasty with or without stenting damages the treated blood vessel, and as a result, increases inflammation in the treated vessel, which promotes restenosis and increases the risk of recurrent coronary events. Restenosis rates are reported to be anywhere between 16 and 44%. Revascularization with angioplasty or with thrombolytic medication can be life-saving during an acute coronary syndrome like unstable angina or a heart attack. And according to the American Heart Association and the American College of Cardiology guidelines, revascularization is only appropriate when severe coronary artery disease is suspected to be the cause of either depressed left ventricular ejection fraction or transient heart failure, or when severe coronary artery disease is suspected as the cause of severe ventricular arrhythmias. So applying these standards nationwide would cut the number of catheterization procedures significantly. Angioplasty is performed on more than 600,000 patients a year as an alternative to bypass surgery and costs more than $12 billion annually. So one study of more than 140,000 procedures found that nearly 12% of them were completely unnecessary and another 38% were questionable. So it's clear that these procedures should be reserved for cases of emergencies and should be followed by aggressive lifestyle change therapies. And chronic stable angina should be treated with lifestyle. Okay, so here we come to the prescription. So in order to reduce our LDL or bad cholesterol levels, you have to dramatically reduce the intake of trans fat, which comes from processed foods and is also found naturally in meat and dairy products. We'll also have to reduce saturated fat, which is found in animal products and processed foods with palm and coconut oils, and to a larger extent, dietary cholesterol found exclusively in animally derived foods, especially eggs. Small decreases in fat intake do not appear to lessen or stabilize atherosclerosis. Effective change requires limiting fat intake to less than 20 grams per day, consisting of 6 to 10 grams of polyunsaturated fat, omega-6 and omega-3 fatty acids in about equal proportion, less than 2 grams of saturated fat, and the rest as monounsaturated fats. Trans fats, which are highly atherogenic, should be avoided completely. Fats should also be consumed in their whole plant form because oils can cause inflammation, promote weight gain, and can lead to an excess of omega-6 fatty acid intake. It's important to note that endothelial dysfunction can occur after just one single fast food meal. A study that evaluated vasodilation and endothelial function found that healthy, normal cholesterolemic volunteers had a 50% reduction in their arterial relaxation just 2 hours after eating a sausage and egg McMuffin. The inflammation resolved in around 5 to 6 hours, but that was just in time for the next meal. So, heme iron from a red meat also produces oxidative stress and contributes to oxidized LDL and atherosclerosis too. Saturated fat appears not only to be a problem with meat consumption, almost all meat is contaminated with bacteria. And these bacteria produce endotoxins that survive the cooking process and can trigger inflammation. The endotoxins in the intestines are carried across the intestinal wall in the bloodstream and trigger inflammation in the blood vessels. Animal foods also tend to be high in choline, which is converted by gut bacteria to something called TMAO or trimethylamine oxide, and is associated also with cardiovascular disease. Okay. So, fruits and vegetables decrease the risk of coronary atherosclerosis. Phytochemicals called flavonoids, which are found in red and purple grapes, berries, black teas, red wine, and dark greens, appear to be protective. Oxidation of the LDL is an early and important step in the development of atherosclerotic plaques, and one of the reasons that antioxidant rich foods happen to be protective. However, there is no data, clinical data, indicating that flavonoid supplements instead of foods actually prevent atherosclerosis. The PREDIMED study was a dose dependent, the PREDIMED study found that there was a dose dependent relationship. So every serving of plants extends lifespan, and each serving of animal protein decreased it. So cutting back on animal proteins by 2/3 to one serving a day instead of three reduced deaths by more than 40%. In certain types of carbohydrate, increasing certain types of carbohydrates to compensate for decreasing saturated fats in the diet increases plasma triglyceride levels and reduces HDL levels, which is the good cholesterol. So, any caloric deficiency should be made up with plant proteins and unsaturated fats rather than simple carbohydrates. Excessive fat and refined sugar intake should be avoided, especially in people at risk of diabetes, although sugar intake has not been directly related to cardiovascular disease. Instead, consumption of complex carbohydrates that are high in fiber, like vegetables and whole grains, is definitely encouraged. Increased fiber intake happens to decrease total cholesterol and may have beneficial effects on glucose and insulin levels. Daily intake of at least 5 to 10 grams of soluble fiber, such from things like oat bran, beans, soy products, and psyllium, is recommended. And this amount decreases the LDL by about 5%. Insoluble fiber does not appear to affect cholesterol, but can confer other health benefits, such as the reduced risk of colon cancer, by stimulating bowel movements or reducing contact time of the fecal material that has dietary carcinogens in it. It reduces the contact time, moves it through. However, excessive fiber can interfere with the absorption of certain vitamins and minerals, but in general, foods rich in phytochemicals and vitamins are also rich in fiber. So nut consumption. Nut consumption has actually been shown to be advantageous. The Nurses' Health Study revealed that replacing one daily serving of red meat with one daily serving of nuts was associated with a 30% reduction in the risk of coronary artery disease. And eating eating 5 or more servings of nuts per week is estimated to reduce the risk of coronary artery disease by 35%. Long-term studies have shown that eating nuts and seeds protects against sudden cardiac death, reduces total and LDL cholesterol and inflammation, and is associated with longevity. A 2010 study found that eating 1.5, and 2.4 ounces of nuts per day was associated with a reduction in LDL cholesterol by 4.2, 4.9, and 7.4% respectively. Similar improvements in blood lipid levels was seen with avocado consumption. And in the Adventist Health Study for individuals over 84, there were 39% fewer cardiac deaths for those that ate nuts and seeds 5 times per week compared with those who ate fewer nuts. And this effect was especially pronounced in the vegans in the study. Vegans who did not consume nuts lived no longer than the intermittent meat eaters, but vegans who did consume nuts lived the longest. And nuts alone accounted for a 5.6-year difference in lifespan. And I know that there's going to be a question after this, probably from Bill, about nuts. So we'll come back to that later. Alcohol increases HDL, the good cholesterol, and has poorly defined antithrombotic, antioxidant, and anti-inflammatory properties. These effects appear to be the same for wine, beer, and hard liquor, and occur at moderate levels of consumption, which is about 1 ounce of alcohol, which is the equivalent to about 2 average servings of an alcoholic beverage 5 times per week. And that has shown to be protective against coronary atherosclerosis. However, at higher doses, alcohol can cause significant health problems. Thus, the relationship between alcohol and total mortality rate is J-shaped. So the rate is lowest for men who consume less than 14 drinks per week and women who consume less than 9 drinks per week. People who consume greater amounts of alcohol should cut back. However, clinicians should not recommend that non-drinkers begin consuming alcohol based on any apparent protective effect. Supplements. So there's very little evidence that dietary supplementation with vitamins, phytochemicals, and trace minerals reduces the risk of atherosclerosis. This includes fish oil supplementation. So as described in the diet and angina randomized trial, which was DART-2, this involved over 3,000 men with stable angina. They were advised to eat fatty fish, but it did not reduce mortality. And taking fish oil capsules was associated actually with a higher risk of cardiac and sudden death. And there was a large 2012 meta-analysis that was published in the Journal of the American Medical Association, and that found no benefit with respect to all-cause mortality, cardiac death, sudden death, a myocardial infarction, or stroke. Coenzyme Q10 is an endogenously synthesized lipid antioxidant that scavenges free radicals, and it's necessary for the basic functioning of cells. So it's synthesized using HMG-CoA, which is the same enzyme that's used to synthesize cholesterol, and it's also the same enzyme that statins block. Now, this may explain why statins cause myopathy or muscle pain, and the increased risk for developing diabetes. CoQ10 is also known as ubiquinol, but when it's used as an antioxidant in the body, it becomes oxidized to ubiquinone. At that point, to be used again, it must be converted back to ubiquinol. So the novel way that this occurs was recently discovered, and it's really cool. So dietary chlorophyll from green leafy vegetables interacts with the red light waves that can pass through the human skin, and the ensuing chlorophyll metabolites catalyze the reduction of ubiquinone back to ubiquinol so it can be recirculated and reused. Levels of coenzyme Q10 tend to decrease with age and may be low in patients with certain heart and other chronic diseases. Because of this, coenzyme Q10 supplementation has often been used or is recommended, but its therapeutic benefit actually remains very controversial. Avoidance of statins, consumption of green leafy vegetables, and exposure to sunlight might be a better strategy. So regular moderate physical activity, such as 30 to 45 minutes of walking, running, swimming, or cycling 3 to 5 times per week, reduces the incidence of some cardiovascular risk factors, as well as myocardial infarction and death attributable to atherosclerosis in patients both with and without previous ischemic events. Now, this is consistent with the data that reveal that reduced oxidative stress with regular moderate physical activity. In addition, walking regularly has been shown to increase the distance that patients with peripheral vascular disease or claudication can walk without pain. It's important that physical activity recommendations be tailored to the patient's baseline condition. Also, it's important to note that exercise is not requisite, okay, it's not required for atherosclerosis reversal. From Dr. Esselstyn's work, we know that aggressive dietary changes alone are sufficient. Okay, so diabetics with advanced heart disease do demonstrate survival advantage with the use of aspirin. But in lower risk people without advanced disease, aspirin does not enhance lifespan and has more hemorrhagic strokes with no benefit to compensate for this. Likewise, a large 2009 study of diabetics without known heart disease who took daily aspirin had a 17% increased risk of death at age 50 and a 29% risk by age 85. So let's see. So aspirin has both anti-inflammatory and anticoagulant capabilities. And interestingly, salicylates, which is the main ingredient in aspirin, are found ubiquitously in fruits and vegetables, with the highest concentrations being in herbs and spices, particularly cumin. This is likely why herbs and spices, with their high levels of salicylic acid, have such strong anti-inflammatory properties and are protective against chronic disease. Therefore, it may be wise to consume plants with naturally high levels of salicylates to avoid bleeding complications rather than take a daily aspirin for primary prevention. Meditation is also believed to decrease cardiovascular mortality by reducing sympathetic activity, that flight or fight mechanism, as well as lowering cholesterol and reducing negative behavioral activity. Studies have also shown that meditation can improve conditions like hypertension, type 2 diabetes, and dyslipidemia. However, there's a relative paucity of data regarding specific recommendations and their potential clinical outcomes. Sleep is also a very important modulator of cardiovascular function. Similar to meditation, sleep may exert significant effects on the autonomic nervous system. And there's a temporal association between physiological sleep and the occurrence of vascular events, cardiac arrhythmias, and sudden death. So there's definitely a causal link between primary sleep abnormalities like sleep apnea and shift work and cardiovascular diseases like hypertension, atherosclerosis, stroke, heart failure, cardiac arrhythmias, and sudden death. And given the effects of sleep deprivation on cardiovascular function, anyone with sleep quality issues or sleep quantity issues should definitely be evaluated and addressed. Okay, questions?
Thank you, Dr. McKinney. That was a great talk. I have a lot of questions. I'm sure Bill has a lot of questions. And I want to remind everyone that is viewing online to please use the Ask tab to ask any questions that you have. Bill, before I give you a chance to ask your question, I'm going to read one that's already come in. And the question is, David is wondering if the arginine-derived nitrous oxide from the nuts is a contributing factor to the longevity that you were speaking about.
So that very well could be the case. So what we know is that arginine supplements themselves do not help with production of nitric oxide and actually can be very dangerous. But arginine found in food, in whole plant food form, definitely can contribute to that. So I would say the answer is likely very much yes. And the thing that we don't necessarily know is that this is an important point about reductionism. So, oftentimes we talk about that, something like vitamin C is good for you. And vitamin C comes from apples, right? So taking the vitamin C out of the apple and then giving it to somebody doesn't provide the same outcome as if you give somebody an apple and have them eat that. And that's because there are hundreds of other phytochemicals, fiber, nutrients in those plants, in that apple, that also contributes to positive health impacts. The same is likely true for nuts. Arginine is one of those things in there that we know is beneficial because it's in the pathway of nitric oxide production. But how does it interact with all of the other phytochemicals in the nut to actually to do provide the effects that it provides? We don't know. It's one of the great mysteries.
Thank you. One more question from Sarah. Are there particular resources you would recommend for people to learn how to incorporate more plant-based slash heart healthy foods into their diets? And that also includes ideas for meal planning.
Yeah. Um, so I would have I actually, Dr. Esselstyn and I have put together an education program for individuals to learn those exact things. So certainly there are that's an option for people. Dr. McDougall at the I guess it's the McDougall Center. He has tons of information and education, plant-based recipes on his website. Uh, you need only Forks Over Knives. The website is a great site in terms of offering information and recipes. So there are just boatloads of learning opportunities out there, and I can certainly share those with Bill, and those can be distributed as well.
Bill, I have one more from the audience. Can I do that before I turn it over to
Sure,
you?
sure.
All right. This is from Lonnie, and her comment is, "This is great information on the positive impacts of lifestyle changes on cardiovascular disease. But from a public health point of view, what ideas do you have for implementing these changes across our population? It seems like a heavy lift to me, but there should be a place to start."
Yeah, that's a great question, and that is something that I have been working on. So one of the things that I do at Doane University is I create educational courses for both health professionals, but as even those that are interested in the health professions, but aren't necessarily clinicians. And one of the things that we have is, we talk about the Certified Lifestyle Medicine Executive, which is really a focus on how do we implement lifestyle medicine at a population level, because that's really what we're talking about here is population health. Um, and how do we do that? And there are definitely some strategies that can be utilized, but it is a huge heavy lift because there are so many other entrenched interests that don't want to necessarily see the meat and dairy industries be damaged. I do have a colleague that his work is in regenerative agriculture, and so they are their mantra right now is less meat, better meat. And so the idea is that we need to eliminate. I think that starting on the agricultural side is probably where we need to start. Certainly, there needs to be some public health education, but without a switch or without a change in agriculture, even if people adopted these lifestyles, we would not be able to supply the kinds of food that people actually need to eat in order to maintain good health. So if we start with the farmers and provide markets for them to produce the kinds of food that support health, sort of work to relocalize our farming economies, and then start to provide education along with that about what a healthy diet looks like. To me, that's one of the places to start. The other place that we need to start is with practitioners. So one of the reasons I left my practice and went into academia was that I realized that my colleagues did not share my enthusiasm for lifestyle medicine. And that was because, none of us learned any of this in training. And so I left my practice to go back and start to educate the next generation of practitioners differently. So if physicians and nurse practitioners and PAs and nurses and other health practitioners are starting to talk to patients about what they can do to get control over their health, that's also a very important place to start as well.
Great, thank you. Bill, do you have a question for Dr. McKinney?
Yeah, one of the, I know one of Dr. Esselstyn's favorite phrase, there's like the three most unpopular words, a little bit won't hurt you or something like that.
All right,
And,
yeah.
so, but in looking at that and considering modifications to our diets, is it dose related? For example, like you said earlier, if someone reduces meat consumption to once a week versus every day, or makes modifications like that, is that impactful in terms of risk?
Yeah, thank you for asking that question. So, um, so I just want to back up a little bit and talk a little bit about nuts, because as the data are very clear that nut consumption, especially when it replaces meat, is beneficial in terms of cardiovascular risk. We know that. Dr. Esselstyn does not want his patients to consume nuts. Now, the reason is that Dr. Esselstyn's patient cohort that he started with, these patients were extremely ill and with cardiovascular disease. And so he was concerned about the negligible amounts of saturated fats in the nuts that could potentially exacerbate their coronary artery disease. I will tell you that for the vast majority of people outside of that group of folks who is extremely ill, moderation doesn't kill. Okay. But there is a healthy eating spectrum. And I didn't put this slide into my presentation, but I probably should have, is that if over here is the standard American diet, okay, and it's full of white flour, white sugar, meat, dairy, highly processed foods, yada, 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 right? And over here is a completely whole foods, plant-based diet, no oil, no sugar, right? Like, toeing the line, okay? Depending on your current level of illness, right, your current disease state, and depending on your goals, if you're here, you may only need to move this far, right, to get to the desired effects. But if you're way over here and you're very ill, okay, you have cancer, or you have severe heart disease, or you have out of control diabetes, you're going to have to move further and further over here. And the reason is that this is a dose dependent type of thing. Lifestyle is dose dependent, just like, an antibiotic or some other type of pill. The more you do of it, the better your outcome is going to be. So even if you say, well, there's no way I can completely give up meat, or there's no way I completely give up dairy, or whatever it is, if you can compress that and reduce it down significantly, you are going to see some health benefits. But don't be fooled by if you're not meeting your goals, right? If your goal is to lose a certain number of pounds and moving to here didn't get you done, well, then you're going to have to move further over here.
I was also going to ask a question about it was a holiday yesterday, so I happened to watch Dr. Oz, which I never do, but it was on, so we watched it. And there was a report on milk consumption that was really quite astonishing, saying a mega study of milk consumption showed a substantial increase in breast cancer risk, or cancer risk overall. And then, of course, throughout the show, they tried to debunk it as much as they could to say, well, there are a lot of other studies that say that's not true. And again, it's a matter of consumers getting accurate information, especially given the consumption of milk in the country. So I wonder if you've seen anything about that, or.
I haven't seen the new study, but in all of the coursework and literature that I've reviewed for preparing that coursework, we know that dairy consumption significantly increases the risk of not only breast cancer, but other types of cancer. And as a matter of fact, one of the factors, cholesterol, high cholesterol, high fat diets increase the risk of cancer, period. We know that. It impacts insulin growth factor 1, all sorts of other things. But what's interesting to me, and this is part of the whole Institute for Human and Planetary Health, is that bovine leukemia virus, which is found nearly universally in all commercial milk that you can buy off of the shelf, is identified in 37% of breast cancer cells. So 37% of breast cancer cases, when those cells are evaluated, bovine leukemia virus is identified in about 37% of them. And they think that actually might be a contributing factor, because we know that viruses are carcinogenic. The HPV virus, which causes cervical cancer in women, is sexually transmitted. But we know that wives of butchers who handle a lot of poultry, their wives are at an increased risk of developing cervical cancer. So viruses are an important part of our health assessment. It's not just the nutrients or lack thereof in certain foods that cause disease, but it's also the chemical pollutants that are in food, and some of these viruses that are typically zoonotic. They're transferring from animal to human.
Thank
Thank you,
you.
Dr. McKinney. I'm sorry, Bill, we have to end this session now. Unfortunately, there's so much to talk about. This is such an interesting topic and it's so complicated. Thank you so much for your time this morning, Dr. McKinney. And I think if folks want to reach out to you afterward, they can find you on the Institute for Human and Planetary Health website. And I want to
Yes.
thank everyone for joining today. And we hope to see you in the next 5 minutes, rejoining us for our next talk at 11:20 a.m., which is about public health professionals and property managers. And we'll be hearing from Erica Swan and Kristen McCauley. So thanks everyone again for joining. Thank you, Bill, for being here. And again, Dr. McKinney, and we hope to see everyone soon. Thank you.
Thank you.
Thank you.